I wanted to give you an update on the status of our clinical trial. Hopefully you can see it in full screen. Great, thank you. And I apologize ahead of time to Michael because this is going to be a deja vu for him, but from earlier. But he has been so instrumental to this that I think he's a very key member of our team. So I'm excited to see him here. So we have designed a clinical trial for evaluating endocrine therapies in men. And this comes due to the large amount of unknowns and uncertainties that exist in the treatment of men with breast cancer, particularly with regards to endocrine therapy, among many other things, as you're aware. So the first part of the issue is that tamoxifen is currently our only standard adjuvant therapy, or at least the one that we consider the best adjuvant therapy that we have available. And we don't know very well the efficacy of other agents beyond tamoxifen, particularly aromatase inhibitors, which we abbreviate as AI, or aromatase inhibitors with gonadal suppression, medications like Lupron and such, that basically try to reduce the levels of testosterone in men. There are also uncertainties with regards to the efficacy of CDK4/6 inhibitors in men with breast cancer. And this comes to generate quite a significant challenge for us because, as you can imagine, and as you may be aware, in women with breast cancer, these treatments are becoming standard. And in fact, tamoxifen is quite outdated nowadays, at least tamoxifen single agent. And we are stuck with tamoxifen in men because we don't know anything else beyond that, or we know very little beyond that. And it's creating a problem that is becoming bigger as time goes by and as newer endocrine therapy options become available, because we don't know whether they will work in men and what to combine them with. One example of this is CDK4/6 inhibitors, but it's certainly not the only one. So, as I was mentioning, we're stuck with tamoxifen. And because of that challenge, we designed a clinical trial to try to answer the questions that you can see on the slide. So do aromatase inhibitors work in men when they're used as single agent? We do have case reports and even case series of men that do respond, particularly in the metastatic setting, to single agent aromatase inhibitors. So those data suggest that aromatase inhibitors should work in men. Do aromatase inhibitors in combination with gonadal suppression work better than tamoxifen? So in premenopausal women with breast cancer, the use of aromatase inhibitors with gonadal suppression has shown that the treatment is more effective for premenopausal women than single agent tamoxifen or tamoxifen alone, which used to be what we used to give to essentially all of our premenopausal women, essentially prior to 2016 or so. Another question that we have is, does the addition of a CDK4/6 inhibitor increase the efficacy of endocrine therapy? So we know that this is the case in the metastatic setting in women. Men were excluded from the metastatic trial, but they were included in the adjuvant trials. And certainly the adjuvant trials for CDK4/6 inhibitors, particularly for abemaciclib and ribociclib, have shown benefit in the overall population, which included some men in both of those trials. And lastly, if we do use a CDK4/6 inhibitor for the treatment of male breast cancer, what would be the best endocrine therapy backbone? Should we use tamoxifen, or should we use an AI with gonadal suppression? And this is a question that is particularly important because, for example, in Monarchy, most men were treated with tamoxifen, but in Natalie, so Monarchy is the adjuvant abemaciclib trial, but in Natalie, which is the adjuvant ribociclib trial, the study of ribociclib in men with breast cancer, or in men and women, but that included men. In the adjuvant trial for ribociclib, men were asked to be treated with aromatase inhibitors and gonadal suppression, which is a combination that is potentially challenging, but we don't know. And the trial did not give the option of using tamoxifen because there's an interaction between tamoxifen and ribociclib. We still don't know anything of this. And as you can imagine, when patients see us in clinic, they feel even more confused than we do, and we're already quite confused with this. So we need more information. So to try to understand this better, we have designed this clinical trial, which is called ETHAN, which is a phase 2 trial of different endocrine therapies for the treatment of men with breast cancer. And the trial is very complicated, the design, because we're trying to answer several questions, but bear with me and I'll walk you through it. So for eligibility, we are requiring men with stage 1 to 3, essentially non-metastatic breast cancer, that is ER/PR positive or HER2 negative. This essentially captures 90% of men with breast cancer in the United States. We're hoping to enroll a total of 60 men, and we are randomizing them when they're enrolled to one of 3 arms. So arm A, which is the tamoxifen arm, serves as the control arm for the entire trial. Arm B is anastrozole, which is an aromatase inhibitor. Arm C is anastrozole with degarelix. Degarelix is a GnRH antagonist, so it's a drug that works like Lupron, although it works faster than Lupron, but it's basically gonadal suppression with an aromatase inhibitor. So this phase of the trial is a window phase, so it lasts for 3 weeks. It's very short, but it's very important. In fact, you could argue it's the most important piece of the whole trial. At the end of the 3 weeks window, men undergo a biopsy. And what we do here is that we use the biopsy that men had at diagnosis. We don't get a new biopsy here. We use the same biopsy that men were diagnosed with breast cancer, so the biopsy they already had. And we check the levels of a protein called Ki67, the expression of this Ki67 protein, which is a marker of proliferation. So we check the Ki67 levels on the baseline biopsy, and then we also check them at the time of research biopsy here at the end of the window, which is after the 3 weeks treatment. We know in women who are treated with endocrine therapy, with tamoxifen, for example, that the expression of this Ki67, meaning how much Ki67 is present, that amount drops by half when you use tamoxifen for 3 weeks. So in other words, if the expression is a certain amount at the beginning, it drops by half at the end of the treatment. With anastrozole, it does a similar thing in women. It drops by about half or a little bit more, up to 60%. And with the combination of anastrozole and gonadal suppression, it can go up to as high as 70 or 80%. So we're hoping to see the same thing in men. If we find that tamoxifen drops it by 50%, which is what it does in women, and anastrozole the same, then we will have confirmed that anastrozole works in men with breast cancer, because based on how the drug works, the only reason by which the Ki67 would drop is if the medication is doing what it's supposed to be doing in the tumor. And if anastrozole and degarelix work better than these 2 options, then we would expect to see at least an 80% reduction in the Ki67. So after the 3 weeks window, patients go on to the second phase of the trial, which is called the neoadjuvant phase, and this phase lasts 4 months. So the tamoxifen group gets randomized 1-to-1 to continue tamoxifen, again, is the control arm throughout the trial, or adding abemaciclib to tamoxifen. And the other 2 groups, which are groups B and C, get randomized together to either anastrozole and degarelix or anastrozole and degarelix with abemaciclib. In other words, what we're doing here is trying to answer the question of, does adding abemaciclib improve things or not? That's the first question. And the second question is, what does abemaciclib work best with? Does it work best if we do it with tamoxifen, or does it work best if we use it with an aromatase inhibitor with gonadal suppression? Then at the end of the neoadjuvant phase, men undergo surgery. Here at the surgical time point, at the time of surgery, what we do is we measure an endpoint called RCB index, which stands for Residual Cancer Burden Index. So the RCB index is a measurement of how much tumor is left in place in the breast that is removed by the surgery when the surgery happens. So in other words, how much has the cancer shrunk due to the effect of these various treatments? And as we would anticipate, the one that causes the most shrinkage will be the one that has the highest efficacy. So that's the schema of the study. The study has 2 co-primary objectives. The first one is the Ki-67 reduction at the end of the window, which is what we're trying to do to find the answer as to whether aromatase inhibitors alone work or not, and whether aromatase inhibitors with gonal suppression work better than tamoxifen. The second primary endpoint is the RCB index, which is to try to answer the question of, does adding CDK4/6 inhibitor work better than not, and which endocrine therapy partner should we use together with the CDK4/6 inhibitor, in this case, abemaciclib. Now, this study has two co-primary endpoints in a different way than the way we normally see co-primary endpoints in clinical trials in breast cancer. So in clinical trials in breast cancer, sometimes trials will use co-primary endpoints because they're not sure whether the drug will improve overall survival or disease-free survival or both. And sometimes they use both co-primary endpoints, disease-free survival and overall survival, for example, or pathologic complete response and disease-free survival and what have you. But here, the reason we have two co-primary endpoints is because we're actually asking completely different questions in the different portions of the study. And the reason for all of these several questions that we're asking is because obviously breast cancer in men is not as common as breast cancer in women. So enrolling patients is not as simple as enrolling female patients. And we want to catch up with the knowledge as fast and as much as we can with the least number of patients possible, and this will allow us to do that. We will have a number of secondary endpoints, such as measuring levels of essentially estrogen and testosterone in patients, which will be measured before they start treatment and after the end of the 3-week window. And this is to try to understand better the physiologic changes that happen in men when they are treated with this medication. We will look at something called PEPI score at surgery, which is a different way of assessing the response, different than the RCB index. We'll look at safety, feasibility, and also patient-reported outcomes with questionnaires during the entire treatment to capture the side effects that this drug causes, particularly for men. So focusing on questionnaires that are important to men rather than the usual questionnaires that we do for women with breast cancer. So many of you have heard me speak for a while about this trial, and it's been a huge process and a huge team effort in getting it open. And we finally have it open as of October 11 at Dana-Farber. Dana-Farber is the leading site, so it was the site that had to have the trial open first, which we did. We're actually very excited because we have our first patient that is going to consent to the trial this coming Monday, actually. It's a patient that I met almost 2 weeks ago now, and we were waiting on the results of the HER2 FISH to see if he was eligible to participate or not. And in fact, his HER2 FISH is negative, so he is eligible to participate, and he's meeting with me on Monday to sign the consent and start. We're incredibly excited about that. We're also in the process of opening the trial at 8 other sites, external sites beyond Dana-Farber, because we want to capture patients throughout the country as much as possible. So the sites are the ones listed on the slide, include MD Anderson in Texas, Memorial Sloan Kettering in New York, Mayo Clinic in Minnesota, University of North Carolina, Duke, University of Pennsylvania, and Georgetown. And we're hoping that University of California, San Francisco, so UCSF, we're hoping that UCSF will join us on this so that we have some representation from the West Coast as well. We wish we could open to even more sites, but funding has been a bit challenging. And so for the moment, we have those 8 sites, and hopefully we'll be able to expand even further. So last but not least, I want to thank a huge number of people who have helped me a lot throughout the entire process. This includes the members of the study team, which are listed on the left. These are individuals who have helped me a lot through a cooperative group called TBCRC, which is the Translational Breast Cancer Research Consortium, which is a group of academic institutions, which is actually the group that is going to be running the clinical trial, or the infrastructure that is going to be running the clinical trial. Also, many thanks to Sherry and everyone in the Male Breast Cancer Global Alliance and Michael. Michael has been an incredible advocate for the study. He has given us invaluable letters of support when we apply for funding. I want to thank the funding that we were able to successfully obtain for the running of the study, which includes BCRF and ASCO. Without the funding for the study, obviously, it wouldn't be able to be done. And I can't thank them enough for their contribution to this, which is a very, very, very important one. With that, I thank you for your attention and happy to take any.
What are you expecting to see then? May I ask you that in terms of testosterone levels?
Yeah, this is a great question. And actually, I'm noticing now that this slide is actually slightly outdated because with the grant from ASCO, we have expanded the checking of testosterone and estradiol throughout the neoadjuvant phase as well.
Nice.
So we know that using tamoxifen will lead to an increase both of testosterone and estrogen in circulation, and that happens both in women and men. Tamoxifen blocks the receptor for estrogen. So as a result, the physiologic response usually is an increase in testosterone levels and also an increase in estrogen, which is made from testosterone, because it's trying to displace the tamoxifen. The body is basically trying to compete for the estrogen receptor with the tamoxifen. So it's sending more hormones to hopefully displace the drug and still bind to the estrogen receptor. Anastrozole works differently. So anastrozole blocks the making of estrogen in women and in men. And so what we're hoping to see in men treated with anastrozole alone is that their testosterone levels will go up and their estrogen levels will go down. And this is going to be key for us to find out because, believe it or not, when these drugs, anastrozole and other aromatase inhibitors, when they were first developed, which was essentially in the 90s, there were healthy volunteers that participated in those studies. And those healthy volunteers included men, but they were at the age of 15, 16 years old, 22, which physiologically is a very different age than the age of the average man who's diagnosed with breast cancer in the United States, which according to national databases is 66 years old, the median, the average age of diagnosis. So it's possible that anastrozole may have different effects in the amounts of estrogen and testosterone in blood in very young men, which is what we already know, as compared to older men who are the actual patients who we treat with these drugs when we treat them for breast cancer. So we will find out about that. That is currently not well known, the levels of estrogen in men. If the levels of estrogen in men go as low as they do in women, in postmenopausal women, then that will end part of the controversy that has been present for decades about the issues around using anastrozole alone in men. And the last option, the anastrozole and the garlics, is an option that should lead to the reduction of both estrogen and testosterone both, to essentially castrate levels, which is what happens in women, and it's also what happens in men with prostate cancer. Then in the right-hand side of the slide, we don't anticipate that abemaciclib will change the levels that these drugs cause. We do not anticipate that. But because now with additional funding, we're able to look for a longer period of time, we will be able to see if the effect that we see originally is maintained over time. So we anticipate that for tamoxifen, it probably will, but the levels will also decrease a little bit. Will still stay high, but will decrease a little bit because the body essentially surrenders, if you will, to the aim of replacing tamoxifen when that's not possible. That's what we're anticipating we're going to see. We'll find out. This option here, which is the only option we're moving forward with in the neoadjuvant phase, this option should lead to reduced levels of both testosterone and estrogen. And we want to see if with longer treatment, that will remain to be the case, if they will still be low, or whether there will be what we call an escape, meaning that the estrogen level and the testosterone level may go up because the body tries to still overcome the effects of the garlics, for example, which is the gonadal suppression, and still make the hormones that the medication is trying to suppress. So it should not cause an escape. It should still remain suppressed, but we will look into it and we will find out.